Mr. Chairman, ladies and gentlemen. First of all, I would like to thank the ICS organization and Dr. Castro and Dr. Monse for the invitation to be here. And I would like to congratulate Dr. Nitti for his well-balanced presentation. I will add some information to that, if I can have the slides on the screen. This is what I'm linked to. Idiopathic refractory overactive bladder, what should be next? Well, I think if we are a clinician confronted with a patient with refractory idiopathic overactive bladder, the first thing is to ask ourselves, what does that mean? It means exclusion of specific pathology, insufficient effect of maximal conservative therapy, side effects of conservative therapy. We have to ask these questions. Wasn't there specific pathology? Was there maximal conservative therapy? Were there side effects? I see in my practice working in a referral center many patients that are sent to me as diagnosed with refractory idiopathic overactive bladder where these conditions were not there and where reconsidering conservative approach will be necessary. If indeed it is a refractory overactive bladder patient, what should guide them the answer, the question, what to do next? This can be guidelines, this can be our personal experience, it can be the clinical practice and setting of our organization, but perhaps, I'm already concluding my lecture, patient's preference will be a very important element. Having said that, what will guide in a practical situation or decisions is the evidence on individual therapies that are there. And already Dr. Nitti indicated that this answer is not always easy on what is the evidence of individual therapies. We have to reconsider in each individual patient what can be the potential effects versus the side effects, what is the impact on quality of life. And of course, we have the information for groups of patients, but still we all know that these patients with refractory, mostly severe overactive bladder symptoms is very specific for an individual patient. And of course, in the actual situation, we have to take into account aspects of cost-benefit. So let's look at the guidelines. I think even if we have a patient with refractory overactive bladder, we first look to the basic management, and here you have EU guideline that is, I think, quite well accepted. And then we go to the specialized management, and if we run through all this, then you see here botulinum toxin and neuromodulation are the two therapies that are proposed. And in the EU guidelines, for male patients, only neuromodulation is quoted. So that can be already a guide. So as the previous speaker and also the chairman indicated, perhaps the easy question or perhaps the difficult question to answer is Botox or neuromodulation. And already Shakespeare gave an answer on that, so I will try to repeat that today. There is, for the moment, no randomized trial that looks at the value, the efficacy, and the effects of neuromodulation versus Botox. So I think we cannot give at this moment on that question, in a patient with refractory overactive bladder, what is the therapy to propose? We cannot give a fair, honest, evident answer. This trial is ongoing in the United States at this moment, and we're very anxious and curious and enthusiastic to see the results of that, because that will be the final advice for us as clinicians in front of an individual patient. However, I think for the time being, we can more in a philosophic way look at the problem and make a comparison between these two therapies, where neuromodulation is restoring the function of the lower urinary tract and where neurotoxins are removing the function. If there are elements of obstructive voiding, neuromodulation can treat that. Neurotoxins can cause that. If there is concomitant fecal incontinence, neuromodulation can treat that. Neurotoxins won't have a major effect in that respect. Neuromodulation is a reversible therapy, doesn't do any harm. If a patient has been treated, is committed to the effect for a period of 6, 9, even 12 months. And that means that if the therapy fails, you will have to wait a certain time before you can proceed to repeat injection or to switch to sacral nerve neuromodulation. If neuromodulation would fail in those patients where the therapy is not effective as we would have wished it to be, then neurotoxin injection still is a possibility. There is ample proof now that neuromodulation can work for a very prolonged period of time, including, of course, battery replacement. With neurotoxins, we're committed to repeat treatments. Both therapies are approved. Neuromodulation, as the previous speaker indicated, now has experience since 1997 with more than 150,000 implants worldwide. The procedure in terms of neuromodulation has been defined. Many technical innovations have been applied, which makes the technique possible on an outpatient basis. And in neurotoxin, however, there we still have to define, or it seems that the optimal procedure is not established. I hear from colleagues big variation in dosages used and also in injection techniques, whether it is in the detrusor wall, including the trigone, whether it's 20, whether it's 30, whether it's less. And in terms of complications, of course, neuromodulation can provoke complications that for the majority can be treated. And as Dr. Nitti quite correctly pointed out, there is a certain risk established of need for intermittent catheterization and risk of urinary tract infections. Cost effectivity with neuromodulation definitely on the very long term is acceptable, and as Dr. Nitti indicated, for neurotoxins still has to be established on long term. So what about neuromodulation? And indeed, I'm perhaps biased because we are busy with this therapy for about 20 years now, but we can indeed have this vast group of patients that have been treated, and more than 150,000 implants have been performed for urinary and fecal problems. One of the very big advantages without any competition for neuromodulation is the fact that you have this 3-in-1 possibility, that you can treat the symptoms of overactive bladder, that you can treat the voiding problems that are there with a significant number of patients, and also you can treat chronic fecal problems. Dr. Nitti showed these slides. Indeed, I accept the criticism on the study, but it's linked to the therapy that patients will feel, so it is very difficult to do a randomized trial. But at least this study, even with the old technology, could show that also on 5 years there is a very interesting effectivity of this therapy. And we have to bear in mind that these were crippled patients with very severe symptoms. Not only this series, but many other series have shown not the 100% that we would hope for, but at least a success of treatment that, in view of the severity of symptoms, seems to be acceptable. Are there predictive factors to make it better? Well, more and more evidence is coming out of some predictive factors. Age definitely is one, and perhaps this type of information can guide us in making a selection for certain patients or given advice pro-neuromodulation or pro-neurotoxin injections. In my view, based on the concept of restoration of function, neuromodulation can be the first choice, and I think should be considered in any patient. But as I said, after my second slide, I think that indeed the patient, after being well informed, has a very important role to play and will indicate the preference in view of the previous information that I give to you. Advantage is that botulinum toxin is still possible after failure of sacral nerve neuromodulation. In all honesty, we have now initial experience that also in patients that failed botulinum toxin treatment, there is a possibility of restoration of lower urinary tract function with sacral nerve neuromodulation. So, does the guidelines help us a little bit further? Well, they leave it open to us and they say, make your own choice for the time being. So then we can look at the results as Dr. Nitti presented, and then you can see indeed the positive effects, but less than 50%. Then we look to other parameters of effectivity, definitely better than placebo, no doubt. It can be an effective therapy. And again, it's not completely fair to make comparison with sacral nerve neuromodulation because there are no randomized trials. But if you look overall to these figures, the successes seems to be less than with sacral nerve neuromodulation. If we then put the results to each other, clearly there are differences between the two therapies. And if we look at the baseline values in the botulinum toxin group and the baseline value in the sacral nerve neuromodulation group, well, there are significant difference in severity of symptoms. So in the trials that have been performed, there clearly is a different group of patients that were addressed to have sacral nerve neuromodulation compared to the patients that botulinum toxin. So this comparison is very, very difficult and perhaps not fair. What about the global spectrum of the value of botulinum toxin? Are patients so happy with the therapy? Well, you can see here the results of comparison between botulinum toxin and cholinergics, and then you see that the results seem not so wonderful as we would hope it to be. So, having this information in view of the time, we cannot establish all the data that are there, but how to choose? Do we have good predictive factors? Not really, we have some. Is the doctor's preference perhaps the most important? And as Dr. Nitti pointed out, well, I don't have neuromodulation in my practice, so I propose to the patient only botulinum toxin. Is this fair information to the patient, or should we say, well, we have two therapies available? There is sacral nerve neuromodulation with advantages and disadvantages, and we have botulinum toxin with advantages and disadvantages. Of course, if we say there is one therapy which is just a little needle in the bladder and a terrible operation where we have to put a big pacemaker in your buttock, is that a fair information? Or is the information, well, we put a nice pacemaker and with electricity we restore your function, or we put a needle that can cause retention? Is this fair patient information? Well, I leave it up to you. Reimbursement issues and cost-benefit analysis are important. However, more and more information is coming up that can guide us. You see here successes of botulinum toxin injections in patients that stopped anticholinergics because lack of efficacy, or in patients that stopped anticholinergics because of intolerable side effects. Clear difference, so this can guide us. In neuromodulation therapy, this does not seem to be the case. Probably it's linked to the fundamental principle of the different therapies, but anyhow, this gives interesting information. If we look to the patient perspective, then you can see here the differences between the two therapies and appreciation of the patient. So I'm afraid that nor Shakespeare nor myself have a real good answer on the question Botox or sacral nerve or neuromodulation. It still is the question. So overall, what for the time being, till we have more data available, is the correct answer on what's the next after we see a patient with idiopathic refractory overactive bladder? Yes, we can do something, but without too much evidence, what is the best? And so finally, our interaction with the patient, giving the honest information, probably is the best way to decide which is the way to follow. I thank you for your attention.